to me, the treatment of dysynchrony, it's the same way one would approach it. How do you treat the pump failure? You would go with medications after load reduction, beta blocker, ACE inhibitor, etc. How would you treat ischemia? You would treat it with revascularization. Now we have better treatments for mitral regurgitation, percutaneous options, so we want to address that. And then we want to address arrhythmias, people with uncontrolled atrial fibrillation, loss of atrial transport, the negative effects of changing preload, etc., rapid rate, and then the effects of incessant ectopy. And then finally, mechanical electrical dysynchrony would be its own, separate entity that we would address for treatment. So the way that we basically identify dysynchrony with a surrogate, an EKG surrogate, EKG, especially the left bundle branch block, prolonged QRS restoration, which we then infer means that there's differential timing of the activation wavefront to different parts of the heart. So the wavefront might reach the septum, for example, before the lateral LV wall, and then that would then lead to dysynchronous contraction. And we have imaging modalities which basically bear this out, things as simple as 2D echo, where you can see the walls of the heart visibly moving out of sync, to more refined techniques such as tissue Doppler, or in this case strain rate imaging, which actually can measure the actual peak of the motion of the lateral wall versus the septal wall, or the anterior versus posterior to opposing walls. So we have good imaging modalities that can corroborate the presence of dysynchrony. And now, after 20 years, we have a very mature technology or treatment strategy, which is biventricular pacing, which in general is performed by having two endocardial leads, one in the right ventricle and then the other via the coronary sinus venous system, which is actually an epicardial pacing strategy. And after many years, we know that we have well-established clinical benefits, which include acute hemodynamic, including stroke volume increases, reduction of myocardial consumption, improvements in subjective parameters, quality of life, heart failure class, walk time, and improvement in remodeling, improvement in the ejection fraction, and reduction in the end-systolic volume, and then finally harder clinical endpoints such as heart failure, hospitalization, and mortality. We have Class 1 and Class 2 indications for the majority of these patients with prolonged QRS restorations and ejection fractions of 35 or lower with heart failure. And we have multiple studies at this point, but all of these studies keep telling a similar story, which is that there is a significant patient population that failed to respond from this therapy. This non-responder rate can be as low as 25-30% if the clinical response, how do you feel, heart failure, classification, etc., is the endpoint, versus if the endpoint is a remodeling index, then the non-responder rate can be as high as 40%. So still a significant non-responder rate. So I like to classify these into three general categories. One is patient selection, and some of these are self-explanatory, I'm not going to spend time on them, but there are patients with significant comorbidities where it will really be very difficult to get much of a benefit for them. I think there's been a lot of attention on the EKG, and we do get most of the response, or the response rates are higher in patients who have a left bundle branch block. It will really remain kind of that undiscovered country, which patients with a long QRS who don't have a typical left bundle do benefit. There is some benefit in some of those patients, but from the standpoint of identifying the best patients to respond, it will be a typical left bundle, and the absence of that is one of the reasons there is a non-responder. The mechanical variables are not to be dismissed. The subclinical dislodgement of the LV lead, the threshold goes up, so you're losing bivalve pacing. It gets turned off because of frenetic stimulation. So these mechanical variables have been improved significantly with the quadripolar lead, which is really basically the standard. So that's about 90% of the LV leads we use, we're able to get around I think there's increasing attention on physiological variables, which include, is the lead in a position where one might expect resynchronization on the LV wall? Is there matching of these two sites, the synchronous site and the pacing site? And then we have a lot of interest or data on timing, optimizing the timing intervals. There's been attention to the idea that you may be getting ineffective LV stimulation, so pacing into areas of wavefront block or scar where you're not really getting the recruitment of LV pre-excitation and elimination of the dysynchrony. A lot of attention on incomplete biventricular pacing due to other arrhythmias or spontaneous conduction. And then there would be a lot of area of focus, I think, in the future on people that just don't get their resynchronization, even despite all things being done properly, a good LV lead, all the timing parameters addressed, and so forth. So how prevalent are each of these variables? Well, arrhythmia can be seen as that would be loss of effective biventricular pacing, 30%, even a poorly positioned lead, 20%. So these variables are not uncommon in clinical practice. So to hit the first clinical issue, just a reminder of the importance of the value of a typical left bundle. This is the mated CRT study slide probably most of you have seen. And clearly showing that if you have biventricular pacing in a typical left bundle group, they get a very good result in improvement in mortality. The interesting thing is if you biventricular pace people who don't have a left bundle, this study suggests that their mortality might even be worse. Now we talk about lead location. The way that I think most people define this is we like to look at the LV in the RAO and the LAO projection. So we have a basal segment, a mid-cavity segment, and then an apical segment. And then in the LAO, anterior, truly anterior location would be where the distal part of the coronary sinus gives rise to or actually receives the anterior interventricular branch. There would be an anterolateral segment, a straight lateral segment, a posterolateral segment, and then the posterior aspect of the LV, which would be where the middle cardiac vein is. And going back even 20 years, this is an acute hemodynamic study showing that the highest improvement in mechanical contractility was usually seen in the mid-cavity lateral regions. And then this has been borne out again in the mated CRT study, which looked at mortality. The stimulation sites, the patients who had leads that were placed in a apical position did worse than non-apical, meaning basal or cavity, and then patients who had branches in lateral did better than patients with anterior or posterior branches. So corroborative clinical data saying that we really have a best lead location, which would be basal, posterolateral, lateral, basal, and mid-cavity. So this is basically your ideal branch. It's kind of, if you will, like a dealer's choice. Do I go to this branch, which is at the margin? It's actually called the lateral marginal branch. This is one of the venous anatomy is quite a bit more variable than the coronary arterial anatomy, but this is a relatively constant branch. This would be, starts off as posterolateral in the proximal area, but where it's ending up is sort of mid-lateral. But this would be a good patient with two possible branches, whichever one's easier, whichever one gives a better threshold and does not give phrenic stimulation and so forth. However, we get patients like this where we have, anatomically, here's where we want to go, but we've got a diminutive branch, not even clear how far out it goes. And as you can see, the ostial segment has a very acute angle, so it will be difficult to really get the lead out there. And one might end up going in this posterolateral branch with a kind of a posterior location in the proximal segment. But by the time the branch is out onto the mid-cavity, it's more in the posterolateral wall. So this might be a reasonable target vessel. Again, an anterolateral branch really scraggly looking, so difficult to get. Another patient would, again, we've got our sweet spot in the lateral wall, kind of a branch that really not going to get a good lead in there. Maybe you get a bipolar lead, but certainly not a good quadripolar lead. Posterolateral is very posterior, so here the anterolateral branch appears to be a good choice. So we get populations of patients where the anatomy, we're going to end up adjudicating that we put a lead in a reasonable location, but it still may not be that ideal location. So that addresses anatomical. Now electrical findings which correlate with response. And in general, the latest that you can be relevant to the QRS, then that typically correlates with a site where there is more benefit. And it makes sense intuitively that would be the latest site of activation. So if we were to LV pace from there, that would give us the best improvement. This is an example of a patient with a lead in two different positions. And as you can see, in one case, the Q to the LV is 90 milliseconds and then 115 milliseconds at a different site. A surrogate for QLV would be the RV to LV, and that's important to know because the devices are now able to calculate or predict based on the LV lead, which is the best or the latest site. They're not using the QRS, they're using the RV, but because the RV is basically a constant, it's a reasonable extrapolation. And again, when we look at response rates, the longer the QLV, the better. And in general, if the QLV is longer than 50% or longer than half of the interval, then the response rate is better. In this study, it was kind of interesting that a longer, even with the left bundle, I'm not sure how well you guys can see the red, the pointer, but the third one down, the left bundle with a shorter QLV did worse than a non-left bundle with a long QLV. So, and again, it is the case that in a certain population of non-left bundle patients, you can come up with a very long QLV. Those patients probably do get a response. Now, moving away from timing issues into what I like to call ineffective LV pacing. The pacing output's coming out. Myocardium is being stimulated, but from a mechanical standpoint, we're not getting enough recruitment of the LV wall. And this is an old observation, and those of you in the plant, you might have seen this when you're doing an LV threshold, where the QRS morphology will suddenly change during a threshold test. And it has been, the same group looked at their ability to shorten the QRS duration by increasing the stimulus output from the LV electrode. So what's happening is that the stimulation wavefront is moving quicker through myocardium that has slow conduction. And why do we see slow conduction? There are functional reasons, the cell-to-cell connections, which are seen when you pace epicardial, provides a slower activation wavefront versus going through the conduction system. And then also pathological. Sometimes you're pacing the border zone of a scar with hypertensive heart disease and so forth. You're going to have more fibrosis and so forth. So this led to the development of a pacing algorithm called multi-point pacing, where a paired stimulus wavefront can be paced from two different electrodes on the same LV lead. The IDE study showed predominantly that there was the ability to convert non-responders to responders, and then in a comparative study, in one study, they were able to show that the actual response rate was a little bit higher with MPP compared to just straight out of the box biventricular pacing. And this is a patient that we had actually that was non-responding. We were just so intrigued by the fact that the EKG basically really didn't look like he was LV pacing at all, despite a capture threshold that was adequate, and despite putting the VV timing interval with the LV offset more than 50 or 60 milliseconds. We were still having an LV left bundle morphology, and then with MPP, as you can see in V1, we have a R wave now, and it's starting to look like we're getting pre-excitation of the lateral wall. Now, let's move on to incomplete biventricular pacing. And remember, the part of the device is basically looking at a counter. So if it puts out a biv paced stimulus, then it thinks it delivered biventricular pacing. But there could be fusion with sinus rhythm because the PR shortened. There could be, and there will be fusion with atrial fibrillation, and then with VPCs that will either inhibit biventricular pacing or it will, again, have some degree of fusion. And this is not a small percentage of a problem. In this study of over 80,000 patients, they had 20% of the patients with 5% of loss of biventricular pacing. And that was shown to have significant effects on hemodynamic changes, and then also on clinical outcome, heart failure, hospitalization, mortality. In one study, just less than 98%, which is only a 2.5% drop. The other two studies are larger, more like 5 to 10%. So certainly, if you're seeing 5% of loss of CRT by biventricular pacing, that should really raise a red flag. There's good data to support that. Just an example of what you see in atrial fibrillation, you're basically, if you don't have a V-sense response on, you're basically limited by the lower rate. You can see atrial fibrillation will just basically start conducting, and then the sense response typically delivers the LV stimulus after the RV has already depolarized, so it's going to be an ineffective paced wavefront. Another reason that we lose biventricular pacing is incessant VPCs. Again, typically you might see a PVC burden on the devices. All the devices are able to give burdens of VPCs and atrial arrhythmia. It's kind of interesting, most of these PVCs, they're actually not really coming from the disease myocardium. They're typically outflow tract or area VPCs that we even see in patients who have normal hearts, coming from the RV outflow tract, the LV outflow tract, or the coronary cusps or AIV. These are typical areas of enhanced automaticity. And this is an example of somebody that had a left coronary cusp VPC. So what we do, and I think that a lot of places do, and I think this is a good clinical practice, is trying to do your best to select the right patient. Be mindful of trying to get a typical left bundle if possible. And then certainly be looking at 3 months, is there lack of response? Is the patient getting worse? Remember, some people are not just non-responders, but we will call them negative non-responders. They actually even get worse right in front of you. So in 3 months, you could consider trying to determine, but certainly by 6 months, that would be the point to start meticulously looking, is the patient having a clinical response, and also repeating the echocardiogram. And if they appear to not be a responder, then I would be looking at the baseline EKG, go back and see, sometimes maybe you didn't put the device in, maybe they were referred to you, so look at that, optimizing the intervals, look at an EKG, an LV-paced EKG, because then that will give you an idea where the lead is, and then also a BIV-paced EKG will give you an idea how well the optimization algorithms are working. This might lead to doing a chest x-ray to look at the lead site, and then obviously being mindful of the biventricular pacing burden. So this is a patient who has a reasonable implant, but then when we go back and look at the programming, the patient is programmed distal electrode unipolar. So this is a quadrupolar lead that was basically put in this position, and we basically waste the distal electrode because it's an anchor. But it turned out that it has a great threshold, and the patient inadvertently been programmed using that electrode. And when you look at the QLV, it's not very late versus the basal electrodes, and so basically we just switched the programming, and that made a difference for this patient. This is an example of looking at the EKG, and as you can see, in the LV paste, you have a large R wave, basically, and so the axis is superior, so this is kind of a posterolateral position. We can gauge that based on the morphology. So again, if you see an EKG that looks off, then that might tell you to take the next step and do a chest X-ray. This is just old data that our wave in V1 is just a real cheap, easy thing you can do on an EKG. The R wave size has generally correlated with a better response to LV pacing. This is a patient who we did notice that he has a nice left bundle at baseline, but his biventricular paced EKG basically looks like a left bundle, and then we got an X-ray, and as you can see, the lead is basically in the anterior ventricular branch, which we really wouldn't expect much benefit. So we we didn't try and take that out. It's been in there for years, but we just added a lead in the posterolateral or lateral branch. I'm sorry, you can see it hopefully, and then the EKG was completely different, and then this got improved after that. So now you've done everything from the standpoint of making sure you pick the right patient, and then you've also optimized all your intervals. You've ablated his AV nodes, chronic AFib, you've ablated his PVCs, but you're still going to not have a full response. You're still going to have some people who are non-responders. So what can we offer those patients? And there's been a significant increase in, for lack of a better term, physiological or conduction system pacing. It began with interest in His bundle pacing, then that moved on to non-selective His bundle pacing, which then moved on to left bundle pacing, and now I think the correct term is probably left bundle branch area pacing, because it's really it's not really easy to tell for sure by pacing the left bundle itself unless you use really tedious program stimulation techniques and so forth. And compared to this bundle pacing, this is easier, the target is larger, the thresholds are better, it's safer because in some people that get His bundle pacing, they will develop AV block afterward. The lead is more stable, and then so I think that this is where the field's moving. However, the better studies, the initial studies, were really done with His bundle pacing, and this is the His alternative study, which randomized patients into, these patients were eligible for biventricular pacing because of the typical entry criteria of left bundle and LV dysfunction, randomized to His bundle versus standard CRT. There was a significant crossover, so be mindful of that. There were, I think, 14 of the patients, and this was a relatively small study, crossed over to CRT. But as you can see, the benefits of the His pacing were comparable to those of standard CRT. So this has then moved on to left bundle branch area pacing, which is just past the His bundle, and in the LAO you can see the lead is more septal. The area that we're looking for is just past the tricuspid annulus. And again, if you go back to that diagram where you can look at the RAO, where you have divide the heart into mid-cavity and basal segments, then you have an anterior and a posterior. So we're looking for kind of that area right in the middle, just past the basal area. And then we position the lead on the septum with a sheath system, and then make a determination when we finally start to get an R wave in V1, then we know that we're stimulating the left side of the septum. This is kind of a nice slide which basically shows on echo that we've gone through the septum and we're stimulating the septal endocardial site. Again, you have a R wave in V1 compared to the baseline. So there are 4 large left bundle branch area pacing studies that compare to standard CRT, and they show comparable benefits in improvement in ejection fraction and heart failure. If you do a meta-analysis, then you come up with responses that are potentially even better than standard CRT, but that's not a prospective study. So finally, now we're just going to kind of quickly wow the audience with what might be the future. We have some interest in LV endocardial pacing via transeptal. The advantage with endocardial LV pacing would be, again, faster wavefront propagation, being able to take advantage of the Mckenzie fibers that are on the lateral wall. So in this technique, this is a group, Hasseger's group in France, and they did a transeptal and put the LV lead transeptal onto the LV wall. And they were studied a group of patients who failed a typical implant and then also non-responders, and they showed that, pardon me, the ejection fraction improved and composite clinical response was better with both of those groups. And then we might still see some interest in endocardial lead. There is interest in a device that uses ultrasound WISE. And then finally, as many of you know, you've seen cannibalization of the transvenous pacing market by leadless pacing. And all the companies are looking at a potential leadless LV pacing site as well. So that might be something we do too, that could be done via a transeptal on the endocardial wall, or it could be via the coronary sinus tributaries. I think this was kind of an interesting way to develop LV pacing using ultrasound crystal that then gets transduced to a pacing pulse. So in conclusion, CRT non-responder rate remains significant despite advances in lead technology and programming algorithms. Reassessment of the baseline EKG and the chest X-ray position may identify patients who should undergo a revision. Vigilant attention to and management of lower biventricular pacing burdens, which are due to atrial fibrillation and VPCs, should be looked at and should be treated aggressively and is likely to lead to a benefit. Programming parameters can be optimized and provide some benefit as well, and then also looking at the QLV in patients, maybe there's a better electrode they should be using. And then finally, patients who continue to have no response can potentially be considered for left bundle branch area pacing, which would be a revision procedure. With that, I'll take any questions. Charles.
Yeah, on the bundle transfer, are you using a larger screw electrode to get through to the LV septum, or is it just a standard?
Thus far, just the select securely. The risk would be that you would literally, go all the way through. This is an area. It is ripe for disruption technology. It is easy. Gaining the site is relatively easy to most people. Sometimes, in people with LVH, as you start to screw the lead will kind of spin off and ricochet off and start to go parallel to the septum. It's not always a straight shot through, so it's not always the most easy procedure. And to your point, a lead which can be really just stuck there and go in there better. An active fixation lead might be a better lead to use.
And for the LV, idea of facing LV and the all the patients have that quite
Right, and Marachi's data, the ones that didn't, there were some strokes in those patients. So it's a great question, and we have this can spin off interventional guys who will probably weigh in on this, but there is a body of literature in putting devices on the systemic circulation and giving them, for example, what we do with Watchman device. We treat them with anticoagulation than we use dual antiplatelet. So there might be, basically, this would have to be studied, but it would probably be safe. And there are, I recently had a patient who that had a primum ASD, VSD, who we didn't know about it, actually. And he got a pacemaker, and it was in the LV, and the guy had done fine, but he also had atrial fibrillation. So he did an anticoagulation, but he had done fine for 10 years. And I did a literature search on that and found that as long as people are on anticoagulation, the event rates are very low. So it's probably doable, and it just requires a lot of study.
The reason I say that is that every now and then you find that, and I've never done it, you find that inadvertent placement of leads across the ASD
Right.
into the LV, and also sometimes perforation of the septum into the LV, and those patients present with strokes.
Right.
So that's an issue.
Definitely
That's why
possible.
we always do the two lead over the chest X-ray to make sure that leads are in the LV.
Can I ask you a quick question?
Sure.
Why is it that if you lose 5% of body pacing, the person does worse? I mean, 19 out of 20 beats that are normal would seem adequate to me.
Right.
And usually 4% PVC burden doesn't disadvantage a patient terribly. So what's the physiologic mechanism for that?
You know, you asked the same question 2 years ago. Honestly, and it stuck with me because when you have, I mean, I've seen patients and they are doing worse. It's impressive, but it's a great question. Why is there so little margin of error? The data is there, first of all, and I can just tell you anecdotally, especially atrial fibrillation, they're conducting, they're just getting ineffective. And AV node ablation is just a chip shot for a lot of those patients. They really should just get rid of the AV node when there's no benefit. And then PVCs, I would say you already have some data in just a normal heart that once you start to get over 10%, there is some beginning of LV dysfunction, and then over 20% is egregious, obviously. But you do start to see some issues even in a normal heart at 10%. So it might just be in a patient, pardon me, with a cardiomyopathy, the margin is less, and they're also potentially getting the double whammy. They're getting loss of CRT, but they're also getting the desynchronous hit from the ectomy. So it might just be that. It's a great question. It is surprising, and it's one of the reasons that it kind of gets dismissed a lot in practice also.
Well, there's an answer to that from the earlier studies with CRT, when they actually were doing hemodynamic studies and measuring LVEP. The moment you turn on CRT pacing, you can also see, a drop, an increase in LVEP, which is left atrial pressure. So on a beat-to-beat basis, you're already getting a variation in left atrial pressures, and that transfers to higher wedge pressures and more heart failure symptoms. So I think it's there. And even in normal people who have left bundle branch block, if you normalize their bundle branch block with pacing, you can see a 10 to 15% increase in their EF just from having a left bundle versus being normal conduction.
Yeah, but if you have 19 good beats and one bad beat,
I think that's what Richard's question. Why is the margin so small? It is a great question.
One bad apples.
You'll probably ask that question next year.
I
As a matter of fact, we're really going to do a hard literature search.
John, that was a great talk, just like 2 years ago. Now, if you're still sitting here, you've got to be a friend of mine. This is